Dr. Vishnu. So this presentation is regarding the evaluation of myocardial infarction. So it's not a complete guidelines or complete myocardial infarction, but I just want to introduce some facts which we are not usually doing in our hospital. So yeah, if you have gone through this slide, this is called Ischaemic Cascade. You may see over the time, the flow maldistribution leads to hypoperfusion of, and then diastolic dysfunction. Then patient develops systolic dysfunction, which is where we are seeing the regional wall motion abnormalities, and followed by ECG changes and patient presenting with angina. So when you are seeing a echo report with no regional wall abnormality, it does not mean the patient is free from coronary artery disease, right? That's the reason we are progressing on investigation. Some nuclear imaging methods will detect the coronary artery disease in early part, like a hypoperfusion level, we can detect it. So first of all, I'd like to say, what is the universal definition of MI? So the type 1 MI, secondary to acute arthrothrombosis. This is what the purpose of this lecture. I mean, I'm just going to address this type 1 MIs. Type 2 MI, it is secondary due to oxygen supply and demand mismatch, unrelated to acute thrombosis. So in these conditions, you should understand, for example, if a patient having a sepsis or patient presented with a supraventricular tachycardia may have troponin elevation and minor STT wave changes. That does not mean they are having an arthrothrombosis, and they does not need anything management like acute coronary syndrome. The type 3, you may encounter some patient who come with a chest pain and died at A&E before you are doing proper investigations. So these patients, at the end of the day, with the postmortem, you will confirm they have MIs. So these are the 3 categories, especially the medical team can encounter in your day-to-day practice. The type 4 and type 5, usually as a cardiologist, we may find it. For example, type 4, almost all the subcategories are related to stent and its related complications. And the type 5 is related to CABG and its related complications. So what I like to address here mostly, the troponitis is not always STEMI. So the troponin elevation can elevate it with variable condition, even the sinus tachycardias, supraventricular arrhythmia, tachyarrhythmias, sepsis. There are lots of conditions can cause elevation of troponin. So elevation of troponin alone does not necessarily indicate it's an acute coronary syndrome. So if you have gone through the evaluation of atherosclerosis, so in your first decade of your life, you may have normal arteries. There you may have form cells, which is gradually progressing into fatty streak. Then later you will develop intermediate lesions, which leads to arthroma, fibrous plaque later. And at the end of the day, you're going to have complicated lesion or rupture and the MI, the late, almost like 4th decade or after. This picture shows you when you have a cholesterol plaque and you are having a rupture, which leads to formation of non-occlusive thrombus in this region, we call as a non-STEMI. And when the clot is fully formed with fibrin and red cells, everything mixed and full occlusion has occurred, we are going to say STEMI. That means it's fully occluded vessels. So here I like to introduce a term to you, TIMI flows. So TIMI flows, for example, TIMI 3 flow means you are having a normal flow across your artery. TIMI 0 flow mean, like STEMI patient, you have no flow across the plaque or something like, like what you see in STEMIs, there's no flow after the occlusion. Then we say as a TIMI 0 flow. when the patient has a normal flow across the artery, we say it's a TIMI 3 flow. So if they have slow flow, we say it's a TIMI 2. If it is very slow, needs almost like 2 to 3 cardiac cycles to the proximal column of the blood is reaching the distal part of the heart, then we say it's a TIMI 1 flow. So when the patient is presenting with various, for example, chest pain, neck pain, diffuse pain, bilateral arm pain, anything below your jaw, lower jaw to above your umbilicus region, any pain with exertion can be angina. So when the patient is coming, you are evaluating the chest pain with brief histories, then you have to do the ECG, and depending on that, you will do the troponin also. Then your decision will be whether it's a non-cardiac chest pain or an acute coronary syndrome. Sometimes we come across some other cardiac condition. For example, aortic dissection. We should not miss in acute presentation with chest pains. So if a STEMI mean with the ECG level, we should diagnose the STEMIs. Non-STEMI and unstable angina will be differentiated based on troponin levels. So what is here most important? History. If a patient's pain characteristics, a tightening pain radiating to neck, arm, jaw, anywhere, with the sweating and autonomic symptoms, if you are suspecting ACS, please stick with your history, because you may come across normal ECGs even with STEMIs. For example, if a patient is having a circumflex artery occlusion or a venous duct occlusion, even sometimes in left main artery occlusions, you may have normal ECGs in the initial part of your evaluation. So if your history is suggestive of ACS or angina, please stick to your diagnosis. So before I am proceeding into main lecture, I like to show you a case which will give you an overall idea about this lecture. This case was performed in 2016 at National Hospital. A 65-year-old gentleman admitted to General Hospital Ratnapura with chest pain for 5 hours. Expected transport delay to NHSL almost like 3 hours with traffic and other conditions, So his risk factors wise, he's a diabetic, hypertension, and smoker. ECG clearly shows anterior STEMI. So the questions here are, what is the best treatment? What are you going to do? So 65-year-old anterior MI with risk factors like diabetes, hypertension, smoker, and this is a Ratnapura Hospital is a non-PCI capable center. So what we are going to do, what is the best treatment? What are you going to do? So what is important here, we should know, STEMI management, time is muscle. Every minute you are wasting, patient is losing the cardiac muscles. That means the cardiac function. That means you are increasing the complications. So the time is muscle. So our target is to achieve prompt, complete, and sustained reperfusion. That means TIMI 3 flow. I have already told you about TIMI 3 flow in the infarct-related artery. So this graph shows you the amount of myocardium we can salvage depending on the hours where we are doing the intervention. If you could see, first 3 to 4 hours are the very vital period where you can see lots of myocardium can be salvageable during this period. After 12 hours, you can see the amount of myocardium that we are salvaging is very minimal. So the time is muscle, so act quickly. So just imagine a patient is getting the symptoms onset now, and patient is deciding to go to hospital. So this is a patient's delay. This may influence the outcome of the condition. For example, if a patient is well knowledgeable about these cardiac conditions, he may reach the hospital early. That will give us to save lots of myocardium. But if patient decides it's a gastritis and he's doing a home remedies and thereafter he's deciding to seek the advice, then the patient delay is going to be more. So the FNC mean the first medical contact. But here, the time the patient has reached your door, the first medical contact, within 10 minutes, you should perform the ECG and make the diagnosis. And from this point, you should decide which strategy you are going to choose to do the reperfusion therapy, either by medical thrombolysis or are you going to go for invasive management. So the patient first medical contact onwards, whatever taking time to reperfusion things is system delay. This is the side we should improve ourselves. The total delay is the time to reperfusion therapy. Just imagine, now we made the STEMI diagnosis. If we are in a primary PCI capable center, they are asking to perform the PCI within 60 minutes of first contact to the medical team. If a non-primary PCI capable center, for example, this case in Ratnapura, if PCI is not possible within 120 minutes, if it is possible, it's better to transfer. I mean, for example, if a home or somewhere where you can access the national hospital within 1 hour or so, then that's the best thing to do it. You have to transfer the patient immediately. If you can't transfer the patient within 120 minutes, then do the immediate fibrinolysis. So the first medical contact onwards, within 10 minutes, you are doing the ECG. Within next 20 minutes, you should have given the medical thrombolysis. So this is what happened to that patient, admitted to CCU, oxygen, if there's a low saturation, monitoring for heart failures, arrhythmia, shocks, dual antiplatelet treatment, high-intensity statin, morphine, antiemetics, fibrinolytic therapy, and if there's a hyperglycemia, you may target less than 180 milligram per deciliter, but you should make sure patient is not developing hyperglycemia during the your management. This is for medical students. What are the absolute contraindications for medical thrombolysis and what are the relative contraindications? So in Ratnapura, they are given aspirin, clopidogrel bolus doses, followed by statins and streptokinase, which was available in 2016, right? Not this era. So what is your next step of management? Do you think you are satisfied with the things what have happened now? Now you would assess whether this patient medical thrombolysis is successful or not. How are you going to assess it? The disappearance of chest pain, stable hemodynamics, ST segment resolution more than 50 minutes, 50% at 60 to 90 minutes, and typical reperfusion arrhythmias, for example, idioventricular rhythms. So here, if you got full resolution, that means more than 70% ST segment resolution, that indirectly indicates you that patient has got TIMI3 flow. More than 50% mean either TIMI2 or TIMI3 could be possible. Less than 50, it could be TIMI0 or TIMI1. So our objective of the STEMI management is to get the TIMI3 flow back. So why you should important to assess it early? As I told you, time is muscle. So you can see the various drugs we are using for the medical thrombolysis. For example, ancient days we used streptokinase, and now fortunately we have tenofovir. If you see the TIMI3 flow percentage in streptokinase, it is only around 30% compared to tenofovir, which was 63%. But the primary PSA around 90 to 95% success rate to get TIMI3 flow back. So what are the things you will say as a failed thrombolysis? ST segment resolution less than 50% within 60 to 90 minutes of fibrinolytic administration. Presence of hemodynamic or electrical instability, worsening ischemia or persistent chest pain. So the idea here, your next decision making is going to happen after almost like 1 hour after repeating your ECG. You are giving the first tender place and repeating the ECG in 1 hour, and you are going to make the decision next what you are going to do. So for example, now if you go back to the case one, patient had ongoing chest pain, ST resolutions are less than 50%, and he had mild heart failure. So that's clearly indicate failed medical thrombolysis. So next step, you have to contact the NHS, for example, in this case, and they have transferred the patient there. These are various calculators to assess your risk of STEMIs and things. So depending on your age and your risk factors and hemodynamics, weight, the ECG conditions, and the time delay to treatment, etc. You're making the score, and depending on that, you can calculate risk of death at 30 days. So this is what you have seen. So this patient has come to Ratnavara Hospital, which is a non-PCI capable center. So they have given fibrinolytic treatment within 30 minutes of admission. Then successful thrombolysis, you should transfer the patient for angiogram, but leisurely. That means 2 to 24 hours, you can take the time to define the anatomy, and if necessary, you may perform the interventions. But in this case, it's a failed medical thrombolysis. So that patient is going to go to rescue PCI immediately, preferably within next 120 minutes. So this is the procedure we have performed. You may see the, I don't know, the arrows will, yeah. You may see here, there's a critical stenosis in this part of the LAD. This is the LAD, this is the ramus intermedius, this is the circumflex arteries. This is your left main coronary artery. So you can see here very critical narrowing after the thrombolysis. Here the patient has STEMI 2 flow. You can see how slowly, how many cycles is needed to reach the flow to the distal part of the heart. So it's a STEMI 1 flow, ideally speaking. STEMI 1 flow. In the right side of the picture, you are seeing the right coronary artery, which is only having a mild disease. So we are putting the balloon, and now you can see some flow. This is the STEMI 3 flow. Now you can see how clearly the flow is going very quickly with each cycle, right? Now we are putting a stent here, and which is the final result. So you can see what you have seen earlier and what your STEMI 3 flow, you can see very clearly here. Okay. So this is the overall thing what I had done up to now. So different time is muscle. So your decision must be made on time, and your action should be taken depending on your clinical conditions, etc. So then I thought to talk about some complication, because that's also part of your STEMI evaluation. So you should know what sort of complication you can encounter in some patients, because patient may delay and present with the complications of STEMI, especially in this COVID period. Most of the patients are not willing to come to the hospital because of the COVID testing, etc. So it's better to know the complications of STEMI. So first thing is myocardial dysfunction, right? It can be transient. For example, it's a myocardial stenting is there, so it may have a transient period of myocardial dysfunction. For example, the first case what I shown there, when the patient had a TIMI 0 or TIMI 1, for example, TIMI 1 flow, they may have lots of stenting myocardium. After revascularization, he has a good chance to get a good cardiac function back to normal. So there may be permanent damage. This is dependent on duration of ischemia. As I told you earlier, if you're delaying more than 4 hours, you're losing lots of myocardium. As the same, completeness of revascularization. For example, we have given the tentative place, we don't have any place to transfer the patient, especially what we are facing this situation in Batticaloa. If we can't transfer the patient, you know, there are lots of myocardium is going to damage, which is going to cause a permanent damage to the patient. So the LV dysfunction can be LV systolic dysfunction. So the powerful and independent predictor of mortality, and it can be worsened by other complications like arrhythmia, valve dysfunction, or mechanical complications of MI. The second most thing you should know is the LV aneurysm. Less than 5% of the patient with transmural infarction undergo adverse remodeling. So these patients, surgical aneurysmectomy seems not benefit. I'm sorry about this. Seems not benefit. So we should only consider that if there's a large aneurysm or uncontrolled heart failure or ventricular arrhythmia which is not responding to ablation treatment. These are the three or four indications where you should consider about doing the aneurysmectomy. But otherwise, generally, it's not benefit. I'm sorry about the typing error. Other issue is LV thrombus, frequent complication in patient with anterior MI, even in the absence of apical aneurysm. So the OH, I mean oral anticoagulants. I'm sorry about that. That was a typing error once again. So oral anticoagulants should be considered for 6 months, guided by imaging and bleeding risk. So other complications, secondary mitral regurgitation. That means a functional mitral regurgitation. So LV remodeling with lateral and apical displacement of February muscles, leaflet tethering, and annular dilatation are common cause of secondary or functional mitral regurgitations. This will improve with your reperfusion and aggressive medical therapy. And refractory cases, we may consider about repairing the valve. So RV dysfunction, generally with RV infarction might happen. The typical triad is hypertension, clear lung field, and increased jugular venous pressure. And they may also present with ventricular arrhythmias, AV blocks, and mechanical complications, low cardiac output states, and shock. So the management is simple: early reperfusion and open the RV branch. Avoid preload reducing drugs, for example, nitrates and diuretic things you should avoid here. The second complication is a heart failure. The symptoms, signs, and chest X-ray. The risk assessment based on CLIP classification, you may find that in your Kumar and Clark. Usually it's happened due to the left ventricular systolic dysfunction. So rule out the precipitation causes like arrhythmia, valve dysfunction, and mechanical complications. The next most important thing you should know here is the cardiogenic shock, because it carries almost like more than 50% in-hospital mortality. So we may encounter 6 to 10% of all STEMI cases. Especially these type of complications are higher in our parts because we don't have the PCI centers or anything. So if there's a patients are developing cardiogenic shock, they have higher chance to go into death even. So what is the management? As you know, is the revascularization is the best thing, which is we are not doing other than the medical thrombolysis. Inotropes. So here what you can choose, for example, medical registrars may have idea which inotropes to start in cardiogenic shock. So if a patient has low EF, dobutamine is preferred. If patient has low blood pressure with heart failure features, etc., no adrenaline is preferred over your dopamine. So mention about this Levosimendan. I will mention in the next slides in detail about that. And the last one is the intra-aortic balloon pump. This is for cardiologists, so I'm not mentioning very much there. So this is, I thought to tell you about these things because we are not usually using these drugs here. Better to, for medical registrars, this will be a best thing to know. So Levosimendan is a calcium sensitizer that increases the contractile force of the myocardium by
I think that's
increasing the intracellular calcium concentration, a contractility. Its effect on them is causing that. So this is the trial which was done in 2002. Right. So you can see this Kaplan-Meier curve shows, especially if you give the infusion of Levosimendan, the first 6 hours and 24 hours, if you compare the mortal death and worsening heart failure, you can see compared to the placebo group, a significant reduction in those two. As the same, when the survival after 180 days of infusion, you may see Levosimendan group has significantly lower chances of death compared to placebo group. So another drug I like to mention, because usually in our hospital we are using the spironolactone. If there's a less than 40% EF, we usually prescribe spironolactone. Another group we usually forget because of lack of availability of the drug in the hospital, eplerenone, is a selective aldosterone blocker in patient with LVSD after MI. So you can see it's significantly reduced all the things. For example, death from any causes, rate of death from CV causes of hospitalization for CV events, and sudden deaths from CV causes. All the things are significantly reduced with eplerenone. The third complications, but you should know, is a rhythm disturbances. So if you see an AF patient, acute AF during STEMI, this is the most frequent supraventricular arrhythmia, almost like 21% chance you may have a AF during the STEMI. Usually we are adapting the rate control strategy. So this AF could be pre-existing, or it could be detected first time, maybe a new onset. So once the patient with the STEMI, we usually loading with antiplatelet treatment, beta blockers, and ACE inhibitors, and early onset of statin. And some studies shows the new onset of AF will be reduced with this type of initial treatment. If they start very early, this type of chances are very less. So presence of AF is associated with higher reinfarction rate, higher stroke rate, higher risk for heart failure, and increase the risk of sudden cardiac death as well. So what is the management? So here you can see the green colors indicates level 1 indication, yellow ones are level 2. So that's the reason I got to mention the clear things. So we are adapting the rate control strategy in AF management during MI, because there's a high chance, even if you use the rhythm control or shock, there's a higher chance it may revert back to AF. That's the reason we are targeting only on rhythm control, rate control in the initial part of the management. So if a patient has AF and there's no acute heart failure or no hypertension, the preferred drug is IV beta blocker. As the same, if a patient has AF, acute heart failure, but no hypotension, then you can consider about IV amiodarone, because you can't give the IV beta blocker during acute heart failure conditions. But if the patient has all three, for example, AF, acute heart failure, and hypotension, in such circumstances, you may consider IV digoxin. Consider cardioversion if rate control cannot be achieved with drugs in critically ill patients. Long-term anticoagulation in documented de novo AF during acute onset of STEMI depends on Chatsworth score. So depending on the Chatsworth score, if you have 2 or more, you may think about starting anticoagulation management. The second thing you should know is VT and VF. So 6 to 8% of the persons develop significant VT or VF, which may compromise the hemodynamics also during the management. So IV beta blockers are good for polymorphic VTs with VF or not. And prominent complete revascularization, once again, the revascularization will stop this rhythm problem. And if there's a recurrent polymorphic VT, you may consider about starting IV amiodarone. And don't forget, correction of electrolytes. Always do an ABG if there's an arrhythmia or cardiac arrest. So prophylactic antiarrhythmic drugs are not recommended. So class 3. So you can't just start amiodarone or anything just to prevent something. And the third, another complication I'd like to mention here is bradycardia, AV block or bradycardia, maybe component block, etc. Especially with the inferior MI, we are getting the heart blocks. So that is usually supra is bundle. So those have usually resolved spontaneously or otherwise after reperfusion. So you can wait even if the patient had a complete heart block. And if the resolutions are good, you may wait. If there's an asymptomatic patient, you can wait even up to 5 to 7 days without going for pacemaker. But if the patient has an anterior MI with heart block, that is going to be usually infra is bundle. That means higher mortality rate due to extensive myocardial necrosis. So this type of patient, anterior wall MI with heart blocks, always keep an idea that's a high risk MI. So just to see another case, a 55-year-old patient presented with a chest pain for 3 hours. This is the ECG. What is the significance of this ECG here? You may see the V1, you are having a right bundle branch block with ST elevation in V1, V2, V3, and some ST elevation in V4. So the RBB, acute onset of right bundle branch block with ST elevation MI. What it is indicates? This indicates patient have occlusion at the before, that means proximal LAD or before that. That means your left main coronary artery or up to your first septal branch in the LAD, you may have the occlusion. That means that patient is a very high risk patient, right? So this is the angiogram. You can see the left side angiogram after left main coronary artery, a thrombus and occlusion, fully occluded. The right side is flowing. So we are wearing the system and we are spreading the clot. So you can see, I don't know, you can see here, not a clot will be there. There is aspiration catheter. We are spreading the clots here. And then we are ballooning the things. This is the balloons. We are ballooning and inflating the things. Now you can see, yeah. Now we are making the stenting. You can see what you have seen earlier and what you are seeing now. This is a best thing with interventional cardiology. You can see save lots of lives and you can save the myocardium as well. So the fourth complication is mechanical complications, sudden hypotension, recurrence of chest pain, new cardiac murmurs suggestive of mitral regurgitation or VSD. And what are the mechanical complications you should consider here is free-wall rupture, VSDs, and papillary muscle ruptures. If you take free-wall rupture, the incidence is less than 1%, but mortality is around 20 to 75%. Usually it's happening first week of transmural infarction. So chest pain, collapse, plus or minus electromechanical dissociation. This is how patient will come. Increased incidence noted with old age, lack of perfusion, and late fibrinolysis. So what you should do here is pericardial radiocentesis, and immediately you have to send the patient for surgery after the angiogram. VSDs usually present a rapid onset of clinical duration with acute heart failure or cardiac shock, with a loud systolic murmur occurring during the subacute phase, usually 24 hours to several days after the MI. It can be in anterior, it can happen in anterior MI, even the posterior lateral MIs. Early surgery, there's a high chance of mortality, high risk of recurrent ventricular rupture. The simple reason is, you may see once the infarction has happened, we can exactly define amount of myocardium which are necrosed. So if a surgeon goes and operates a small area, later he will find a big area will be infarct and that will rupture again. So that's the reason early surgery is associated with a high mortality. But still, if a patient has high risk of death, we don't have any other option. But very interestingly, the last thing, the percutaneous closure device closure, which we have performed in Sri Lanka almost like 3 to 5 cases, and we were successful in 2, I think. Papillary muscle rupture, usually acute mitral regurgitation, 2 to 7 days after the MI. But here you should be careful. The patient may have not a good murmur like what you listen in chronic mitral regurgitation, but the echocardiogram will show clear good MR. So if you are suspecting a sudden dyspnea, pulmonary edema, cardiac shock, just suspect some of the mechanical complication might happen. either free wall rupture or a papillary muscle wall rupture or a VSD or something is happening, something is wrong. And the pericarditis. So it might happen in early part or late part. The early part usually after the STEMI and transient. This is what I like to say because most of the initial rescue PCIs time will be missed, and the following day they will call almost like 18 hours or so later saying persistent pain. That persistent pain most of the time due to the pericarditis, not because of ongoing ischemia. So you should act on time. The later part we see as a Dressler syndrome, typically after 1 to 2 weeks of MI. So these are the 4 criteria what you should know about pericarditis: pleural type chest pain, pericardial friction rub, ECG changes, especially you can see widespread ST segment elevation. Usually they will have concave ST elevation and it will be progressive, and you can see PR segment will be depressed in acute phase of the pericarditis, and patient may have pericardial effusion. So among these criteria, if a 2 is positive, then you can consider as a pericarditis. So usually, if there's a pericarditis, for example, after viral infection or something, if you have a pericarditis, we usually use NSAIDs, colchicine, and sometimes even we try corticosteroids. But here you should be careful if in a post-STEMI patient, if you use the corticosteroids, there's a risk of scar thinning with the aneurysmal development or rupture. So don't use corticosteroids after MI. What you can do here is you can give some high dose of aspirin, maybe 500 to 1000 milligram every 6 to 8 hours for first 2 weeks. Followed by gradually you can reduce to 250 to 500 micrograms every 1 to 2 weeks. In addition, you may consider colchicine. After 3 months, if you want, you may consider about anti-inflammatory drugs. I mean, non-steroidal anti-inflammatory drugs, but corticosteroids are not recommended due to risk of scar thinning with aneurysm formation. The pericardial effusion, if you exclude the pericarditis criteria, you may come across patient with pericardial effusion. Unless hemodynamic compromise, we don't need to aspirate that. And I thought to mention this also because there's a new entity, myocardial infarction of non-obstructive coronary artery disease. So we may come across some patients where a patient will have a typical chest pain, ECG might show ST elevation MI, and we will take them to the lab and we'll do the angiogram, and we won't see obstructive coronary artery disease. Obstructive coronary artery disease in the sense, if a patient should have at least 50% or more stenosis in the coronary arteries. Otherwise, we say as a non-obstructive coronary artery disease. So the patient fits with the AM acute myocardial infarction criteria, and there should be non-obstructive coronary artery disease, and you don't have any other cause to say for the STEMI changes. So in such circumstances, you can label that patient as a myocardial infarction of non-obstructive coronary artery disease. So these are some flow charts to see how those patients are managed. For example, patient coming with changes like a STEMI, so you are performing urgent angiography. If you find a stenosis more than 50%, then you will consider that as a STEMI and you will treat according to that. But if a less than 50% stenosis and not and it's fulfilling the acute myocardial infarction criteria, then the MINOCA is one of the possibility. And the rest of the investigation what we are doing has mentioned here. These are in summary what we usually use depending on hours. For example, this flow chart is mentioning what will you do if you are in a PCI capable center, what sort of things. For example, green class indicates level 1 and yellow class level 2 evidence based, and you can see the aspirin and ventolor distractable, the what is the access is good, and everything is mentioned clearly in this diagram. As I say, this is for patient who had thrombolytic therapy and what sort of drugs should be started on what hours and how your decision will go on has been mentioned in this flow chart. You can see within first 24 hours, they are expecting to start ACE inhibitors, beta blockers, dual antiplatelet treatment, and statins. last but not least, so this is a recent trial that you can see is a June 1st, 2021. It has been published. Optimal medical therapy and 10-year mortality after revascularization. So we may do any advanced work with the interventions, bypass, etc., etc. But continuing the medicines for a long time is most important to get a good, to prevent your mortalities. You can see here in the blue line, they are mentioning patients who are not on any medication after stenting or bypass, or patients who are on 2 types of medication. They have almost like 20% chance to have death in 10 years. Compared to them, persons who are on 4 types of medicine, especially one whatever the usual medicines, they have only 12.7% chance to have mortality. The p-value also very significant. The most important part of the management here is continuing the medicines. These I thought to share with you. Anybody have any idea about this ECG? I think you all can speak, am I right?
Yeah, they can unmute.
Anybody like to answer this ECG for me, please?
Yeah, there are a few postgraduate trainees in medicine, so you can answer the question.
Anybody would like to answer this question? What is the diagnosis here? Otherwise, what you are saying in this ECG, can you say me? No answers? Okay, no problem. You can see here in the V3 and V4, there is a ST segment depression followed by very hyperacute T waves. This is called deep winter T waves. Deep winter T waves. This type of patient may have proximal LAD, or before that they may have the lesion. So these are, for example, these patients won't fulfill the criteria for thrombolytic treatment, but these patients must send for intervention at earliest possible. So these patients are very high risk patients. And anybody would like to interpret this ECG?
You can type your answer in the chat box also. There were 3 correct answers for your previous question. Deep winter.
All right. Okay. Thank you. I didn't see that, honestly. Okay. Very good. Okay. Anybody wants to answer this question?
You can type it into the chat box.
I'm seeing for you all.
There's
very good.
Answer. Yeah.
Dr. DU, you have done very good answer. Yeah. So what you are seeing here, ABR ST elevation with 8 or more leads ST depressions. So these type of patients may have left main coronary artery occlusion. This is also one of the most dangerous condition. For example, you can see when these patients are coming to you, you may see non-nest elevation MI. That is what your mind will do. But this is not, this is beyond that. That is the reason I told, if a patient is coming with symptoms such as your angina, don't just trust on investigation. Trust with your clinical judgment. So what is the diagnosis here? Yeah, Galaxy A50. You are saying the correct answer, and once again, DO also saying the correct answer. So this is the posterior MI. So this is why I mentioned this ECG. I know this is the ECG you can easily diagnose. A person without experience will say is a non-nest elevation MI, but this is a posterior ST elevation MI, and there are some 2, 3, and AV false ST elevations are there. So if inferior MI patients are coming, please don't forget to take additional leads. That is the reason the ECG forms, they clearly mention standard leads plus additional leads. The additional leads must include, especially in inferior MIs, are this V7, V8, and V9 as the same V4R, V5R, because you can mention even the right ventricular infarction also, you have to look for it. So V1, you can see some elevation in RV infarctions. As the same V4R, V5R leads also is better to do, especially in inferior MIs. I think that's all my slides, probably. Yeah, this is a video maker. This is for your learning purpose, right? Tombstoning. So these type of patients are also really high risk patients. The tombstone appearance, but they say, especially in the ECG, you can see tombstone appearance. Okay, these are very high risk patients. Thank you. You may ask some questions from me now.